I think since today morning, you have been hearing lectures about various aspects of the EEG. We started with the technical aspect, then we went into the normal and the abnormal EEG patterns. The whole purpose of this exercise is ultimately to interpret the EEG and translate it into a EEG report, which by reading which the referring physician or the neurologist or psychiatrist or pediatrician, whosoever has referred the patient to you, should be able to get an information regarding the diagnosis based on which the management can be initiated. So that's what we are going to discuss during the next 20-25 minutes. How to systematically read and frame an EEG report. We are going to cover two important areas here. For example, if you have to correctly report the EEG, you have to have correct interpretation also. So how to improve the reading and interpretation of the routine scalp EEG. And secondly, how to improve reporting a routine scalp EEG, or how to make the EEG report more objective. How to improve the reading and interpretation of the routine scalp EEG. Let us try to answer a few of the questions you would like to ask yourself, whether EEG to be read independent of the clinical data or not. All over the world, there is considerable amount of controversy whether you should be provided with all the information before you read the EEG. But the problem with that, as we discussed briefly in the morning, you may be biased. For example, if somebody has mentioned that they strongly suspect an epilepsy, then every kind of waveform, because all of us are human beings, there may be a tendency to make even benign epileptiform pattern as epileptiform. Ultimately, the clinical diagnosis may not be exactly what it was meant for. So what is usually recommended in most of the good EEG lab is read without the full clinical data. For example, to start reading the EEG, you require the age and the state of consciousness of the patient, and the patient is on any medication which could influence the EEG. Other than that, you should be blinded for the rest of the clinical data, and after you have seen and made up the EEG diagnosis, go back into the rest of the clinical data before you make an electroclinical correlation. This is a better way of doing it. You may say that more unbiased way of reading the EEG. Second question is whether one would like to overread or underread EEG. Preferably you should not do neither of them, and one has to correctly read. But this requires a good amount of experience, and initially you have to be supervised or mentored. In the absence of that, at least do not overread. We already discussed that overreading, the amount of consequences which can occur if you make a non-epileptiform pattern as epileptiform, and finally which leads on to many things like initiation of the treatment and all the sequelae related to that. In this area where each one of us are busy, you might ask a question, should I read the EEG from the first page to the last page, every page? It's absolutely necessary, because as you know that many things which are happening in the EEG are paroxysmal. They may not be present in the EEG except for the last 2 pages. So if you miss out them, then the whole purpose of getting the EEG done and your reading becomes futile. So try to read the EEG from first page to the last page. At least somebody should. For example, if you're a consultant, your fellow might have read it and he has marked certain places. Or if you've got a good experienced technician who can recognize all the suspicious areas that has marked and you have gone through them. But ultimately somebody reliable should cover each one of those pages. So that requires time. For example, EEG reading cannot be done in a hurry. So if you are if you have to go for your lunch or to see the patient or you have been called to the OPD, don't start reading the EEG within the next 5 to 10 minutes. Better to leave that and then come back at a time when you have got the time and to read the EEG. The second thing what is recommended is when you read the EEG, you have to have at least about a hand distance, 1.5 distance away from the screen, and you should be faced at the middle of the screen. And once you start reading it, when the pages are moving, don't look away from the page. If somebody has walked into the room or wanted to discuss with you something, stop whatever you are reading and then come back to that. Otherwise, you will miss certain pages which may be the only ones which had the abnormality, so that totally ultimately your reading has become ineffective. All of us have been taught right from childhood that if you are systematic, you are less likely to make mistakes. And I don't think there is any other investigation where that systematic approach is more required than the EEG. These are the 5 steps through which EEG reading should go, irrespective of your experience. In spite of having more than 30 years of experience in the EEG, I still go through these steps of reading the EEG. So let us go through that way. Some of them we discuss. Step 1 is interpretation of the background activity. As you mentioned, that how crucial it is, because it is based on this, you have to build the rest of the abnormalities in the EEG. And as the background has to be defined in relation to the age of the patient and the state of the patient as normal or abnormal. And if there is an abnormality, you have to say that whether it is focal or generalized. And we also discussed that the second step is the identifying the transients. Transient is any kind of waveform which need not always be sharp, which is different from the rest of the background that is standing up against the background. More often these are artifacts, but then you have to identify this. You already had a session on artifacts. You have to conclude that whether it is originating from the brain or cerebral transients, which are those are the ones which we are interested in. And once you conclude that these are cerebral transient, the step 3 is whether to say that this is normal or non-specific or epileptiform. Many transient which you have seen, majority of the transients are physiological, like you saw the lambda, you saw the post, you saw the V wave, K complexes. These are all the transients which are standing up against the background. So majority of the transients are non-physiological, or there may be some kind of non-specific slowing which comes intermittently, especially in the elderly. For example, the temporal slow wave transient of the elderly is a normal phenomena. Or whether they are epileptiform. These are the ones which we are interested in relation to the diagnosis of epilepsy. And the 4th step is that if they are epileptiform transients, then you have to distinguish between the genuine and the benign epileptiform variants. Because this is where most of the mistakes are made, by misidentifying benign patterns as genuine epileptiform pattern. So the 4th step is an extremely important step, and we'll come back into that. And once you have defined it as a genuine interictal epileptiform discharges, then you categorize them as focal or generalized, and each one of them may occur randomly more often, or they may occur recurrently or in a periodic pattern. You heard the lecture by Dinesh. And then whether they are occurring, whether they are provoked, like the photoparoxysmal response or hyperventilation response, etc. we had, or they are occurring spontaneously. And in each one of these steps, for example, a distinction between, as I mentioned, the 4th step is where most of the mistakes in EEG reading are made. So I'm going to provide you, this is John Dunn and myself. He's an Australian EEGer. Both of us had training at the Mayo Clinic, and we both of us tried to name it as like 10 commandments here, there are 5 commandments which each of the new EEG readers should understand. Every spike-like waveform is an artifact or a normal variant unless proved otherwise. It should not be the other way around. That is how the overreading and the misinterpretation of the EEG is made. A genuine spike should have a definite electrical field that if they don't have a kind of polarity or the field, then that should be concluded as an artifact. And third one is the pathological spikes are almost always surface negative, and positive spike-like waves are more often normal variants. The classical example is a post. We have been told 2-3 times how to distinguish between a post and a occipital epileptiform. Occipital spikes or the sharp waves. The 2-minute rule is that if you are unable to decide within 2 minutes with your experience and the knowledge in the EEG, whether it's a normal variant or it's a genuine epileptiform, conclude for the former, that is a benign variant, and try to consult an EEG expert. Don't conclude that it's a pathological, because that has got a lot of connotation as far as the management of the patient is concerned. Ultimately, it's better to miss an epileptiform pattern than to misdiagnose, because somebody else might be, who is an expert than you, maybe correctly diagnose it. But you should not be the person who are misdiagnosing as a benignness and pathological pattern. So always remember that most of us our ego prevents us to get an opinion from your colleagues, whether it's senior or junior. But remember that seeking a second opinion shows your strength, not the weakness, because you learn more, and that way you will be better informed regarding that situation, and which can be translated into the management of the patient. Recently, if you ask me that out of all the slides which you have seen today, which is the most important slide which you want to keep in your mind, this particular slide is the one which each one of you should spend time and then preferably read the article, or at least go through this mental imagery and look at the criteria, because International Federation of Clinical Neurophysiology recently defined the 6 criteria, which 6 attributes of the genuine epileptiform pattern, or what you call indirected epileptiform patterns, and out of which 4 should be present, 4 out of 6 should be present for you to define it as epileptiform. Let us go through each one of these criteria. The number 1 is that the morphology of this particular transient should be sharp or spike-like. So that is the most important thing. If it is blunted or something like that, you should not convert it, you should not conclude it into an epileptiform pattern. And the second one is that the duration of this particular waveform is different from the rest of the background activity. That should be the second criteria. And the third one is that if they more often they're biphasic, there is an upstroke and a downstroke. That should not be symmetric. It should be, one is, for example, you can see that the downstroke here is slanting. If it is like drawn up and down, that's most likely an artifact. You saw some needle like the myogenic potential or the muscle spicule and all those kind of things. But here it should be asymmetric. That is the third one. Fourth one is that there has to be an aftercoming slow wave after this sharp transient. And the fifth one is there should be a disruption of the background activity. One might ask about what is the difference between 4 and 5. The fourth one says that there is an aftercoming slow wave, and which would have disrupted the background. But then why to emphasize the fifth one? For example, the slow waves of that type may occur even preceding the spike. So what you are telling is that should be different from the rest of the slow waves, that it should be morphologically it should be different. So that is why the fifth criteria has come up. Last but not the least is that there should be a field. In the absence of that, the physiological field is not there. It has to be concluded as an artifact. So all the beginners whenever you see a sharp transient, that they should go through all the 6 points which have been made, and for you to conclude it unequivocally, 4 out of that 6 should be present. In the absence of that, there is no need of rushing it. You preferably consult somebody who is more experienced than you before making a conclusion, or try to get a longer record or something. You have to define it better, because there were only very few of the sharp transients during the routine awake recording. So you try to get a sleep recording or many a time an overnight EEG before you make a conclusion. Of course, the machine learning, one might say that why are we wasting a lot of time in reading and this thing? Because these days there's an easy answer by machine learning and artificial intelligence, which sometimes, whether it can replace EEG readers like us. So a multicentric European study was conducted with many centers in Europe. They wanted to find out by machine learning how the EEG, whether the accuracy of reading the EEG or the duration we spend in reading the EEG could be minimized or not, or at least in the long run, whether the artificial intelligence can take over the EEG reading from us. These were the questions that they wanted to answer. So through the machine learning, the machine was taught to distinguish between normal and abnormal EEG, and also to further categorize the abnormal EEG into focal epileptiform, generalized epileptiform, and focal non-epileptiform, and the generalized non-epileptiform. And they found out that there is almost more than 80% of the specificity in distinguishing by the machine learning between us. But they also ultimately that in order to verify whatever the artificial intelligence has required, our help is required. So the conclusion was that artificial intelligence can considerably reduce the duration by identifying whether the EEG is normal or abnormal, but whether that abnormal pattern is correctly identified, whether it conforms to the patterns which we know as helping in the diagnosis, the answer at present is not. So still that these kind of algorithms can shorten the time of reading the EEG, and you can spend more time in identifying and analyzing the waveform than going through the page by page by correctly identifying certain pages which you have to spend the time, but they can never replace us. So that this should be considered as an adjunct and not as a replacement for the EEG reading. After having spent time on the reading and interpretation, let us now go into how to improve the reporting the routine scalp EEG, or the other way to ask is that how to make the EEG report more objective. One of the problems in reading the EEG is a lot of subjectivity comes into. For example, there is a saying that if you give the same EEG to 8 epileptologists or EEG readers, there may be 10 reports. So that is why the EEG reading is largely related to your experience, and then the way in which how much time you have spent in analyzing that. And so one will see that how the objectivity can be brought into. We already seen the objectivity, how to distinguish between the benign epileptiform and the genuine epileptiform. So there are a few of the items which should be included in the EEG report. One is at the stage any preparation of the patient, such as sleep deprivation and fasting. And the patient's state of consciousness, if the patient is comatose, a Glasgow coma scale to which the EEG activity can be correlated. And the obtunded sensorium, etc. Dinesh has already told you in an ICU setup, it becomes extremely important. State also any medication which the patient has received, either for regularly, like anti-seizure medication, which like benzodiazepines can produce a lot of fast activity, and or it was specifically administered for EEG recording to induce sleep, and the dosage also. State the number of electrodes only if it is deviated from the 10-20 system. For example, if you are used, the anterior temporal electrodes are routinely used but if the labs which are using it only once in a while should describe that. Or sometimes the midline frontal electrodes anteriorly are used in when you're suspecting a mesial frontal lobe epilepsy. State the duration of the recording, awake only or awake and sleep. Any special procedure which is performed, like the patient has been tested while reading or eating or cognitive task, pattern viewing, these are important in patients referred with the suspected diagnosis of reflex epilepsy. The items to be covered in the EEG report even is already was stated through the 5 steps which we went through. That means initially you describe the background activity, then you describe the transients, the eye-opening response and the hyperventilation. Everything was covered there, and whether the abnormality is episodic or periodic and other things. Describe the activation procedures in detail, and artifacts needs to be mentioned if they are suspicious or you are unable to conclude, or then you should describe it, but otherwise routine artifacts. In fact, artifacts will be present in every EEG. If you are asked something, what is universal for every EEG, irrespective of where it is done, they are artifacts and not any of the activities. That's why their identification and exclusion is extremely important. So ultimately that should lead on to your impression. You state that whether the EEG is normal or abnormal. If it's abnormal, one can have a grading, as Dinesh mentioned to you, based on the percentage. This, of course, approximate. And if the previous record is available, especially in an acute care setting, the present record will have to be compared with the previous one, whether there is a deterioration or improvement. And then you try to make a clinical correlation, attempt to explain how the EEG finding agrees or does not agree with the clinical picture, which will vary depend upon the clinical context in which the EEG is addressed. The abnormal EEG finding are never diagnostic. So always state that they are supportive. Even the most classical of the EEG finding is the pattern of SSP. Even that has got a differential diagnosis. So that you can say that it is supportive, but don't state that it is diagnostic, because there is some limitation in the EEG, because same pattern can occur in a variety of other disorders. There are also the items which should be avoided in the EEG. More often, this is also extremely important. Avoid criticism of the referring or treating physician, that he has made a totally irrelevant diagnosis or EEG is not required or not. In electroclinical correlation, give only 2 or 3 differential diagnoses, not a laundry list of differential diagnoses. Let's say on the previous day you had a table of what conditions which can produce a periodic pattern. Don't put that whole table, but the whatever that rest of that EEG, whether it is a short interval, long interval, whether it is lateralized or whether it is generalized, based on which what are the 1 or 2 differential diagnostic possibilities. And then again, remember that you are only reading the EEG, because if you are not, unless you are the person who has seen the patient and got the EEG done and you have got a chance to report, avoid management recommendation. This patient should have a neuroimaging or some other anti-seizure medication is better than the present one being used. Such statements should be avoided. And International Federation of Clinical Neurophysiology also discourages using the term like spikiform, sharpish, blended, archiform, doffed and all, because others would not be knowing that what do you mean by these terms, because these are not recognized term in the IFCN glossary. And so there are few institutions which translate them into some kind of objectivity, and this is a kind of Mayo system of classification of the EEG abnormality based on their frequency, amplitude, and the way in which they are distributed. This makes more and more objectivity to the EEG reading within that institution, because every consultant, for example in Mayo, has to follow that, so there won't be any difference between what you call inter-reporting the discrepancy won't be there. But between different, for example, I brought this system from Mayo and then started in Sri Chitra, and most of the people who have consultants elsewhere who have studied who had their training in Mayo follow this. But there may be other systems which are followed by other institutions, so that you cannot have this comparison between different institutions. And this is a format of an EEG report. And initially you start with the clinical interpretation and then you describe the EEG finding. You might ask, more often we do the other way around. You describe and make a conclusion. The reason for doing that is many a time the patients are referred more often to you by an internist or by pediatrician, occasionally a psychiatrist, or even neurologists who do not have any specific interest in the EEG. There, if you start describing various EEG forms, which they may not be understanding properly. So what they are interested is, what is your clinical interpretation, whether it is conforming to the clinical suspicion, or it needs to be modified, or it requires additional studies to make a conclusion, etc. And then if they have got any suspicion about your interpretation, they may be able to read the description and say that whether it has been the interpretation has been correctly translated into or the description has been correctly translated into the interpretation and vice versa. That is why you put the clinical interpretation up front and the EEG findings later. And this diagram here is for the technician in order to mark the skull defect, etc., to which any kind of amplitude asymmetry could be correlated. So that is the duty of the technician, which are the electrodes which are coming within that the skull defect area. And let us now, whatever we have discussed up till now, let's now translate it into a patient scenario and then report it. So this is a 15-year-old patient who had an awake and sleep EEG recording. I need to have only this much information. I would like to have only this much information before I start reading the EEG. I looked into the technical aspects of the specification of the EEG that is conforming to what is usually recommended. Now I starting the EEG. All of you have seen that this is a very well modulated posterior alpha of 10 Hertz, which is symmetrically distributed, and that alpha activity is responsive to eye opening. And the EKG showed a rate of around 84, which is regular. And here in the second page, still the patient is awake, and you are finding a generalized burst of frontally dominant spike and waves, which has got an abrupt onset and a termination, because as soon as it's terminated, the alpha activity has come back. Here you know that the alpha activity has gone and some posts are coming, so the patient is drowsy, and in addition to that, here there are polyspikes. Burst is seen, and there are some spike discharges also. Here the patient has gone into deeper stages where these things are getting fragmented, they are asymmetric, and seen on the frontal region, some are generalized. And then I do the photic stimulation, and this is and that shows at 14 Hertz, when the eyes are closed, there is a generalized spike and wave burst, which has outlasted the photic stimulation. Now, after getting all this information, now I see the clinical information, the full clinical data. This is a 15-year-old girl who had brief episodes of unresponsiveness since the age of 5 years. For the last 2 years, she is getting myoclonic jerks, especially in the early morning hours. She had 2 recent GTCS which prompted the consultation. She feels uncomfortable while looking at flickering light and some of the patterns. The referring neurologist has made a clinical diagnosis of juvenile myoclonic epilepsy. Now, this is the report which I wrote. This record shows generalized epileptiform abnormalities and photosensitivity, thereby supporting the diagnosis of genetic or idiopathic generalized epilepsy. These findings support the clinical diagnosis of juvenile myoclonic epilepsy. And that is the body of the report. Recording of the patient awake showed a dominant posterior activity of 10 Hz, which was symmetrically distributed and was responsive to eye opening and alerting. Generalized anteriorly dominant 3 Hz spike and wave burst of 2 to 5 seconds duration were seen. Hyperventilation did not provoke any additional abnormalities. Intermittent photic stimulation showed generalized spike and wave bursts consistently at certain frequencies. The patient fell asleep spontaneously and adequate level of sleep was recorded. During drowsiness, a few generalized polyspikes bursts were seen. Fragmented, lateralized, and focal spikes were seen during sleep without any consistent lateralization or localization. No electroclinical events were recorded. So very concisely, I have conveyed everything I have seen through the report. For example, one should give a very brief report. Nobody would have the patience to read a lot of unnecessary things, and even the sentences should be framed in such a way that it is conveyed through very briefly but very concise and to the point. And this requires a lot of experience, and you have to be initially mentored. When I was underwent training, and other fellows who are from the rest of the world in Mayo Clinic, when they undergo training, we used to go through the reports which have been written by Dr. Klaas or Dr. Westmoreland and take a printout of that, and whenever we see similar patient, we frame the report in such a way. That is how we learned it. I hope you will also do that, and then the reporting will be done in that fashion. So thank you very much for your attention.